All right, so we're gonna go over psychiatric emergencies tonight. It's kind of long, and I'm sorry, but I really enjoyed it, so I don't mind it being that way. So hang on one second. Another instructor's messaging me. All right, so anyway, all right, so we'll get going, kind of dive off into the fun part. Why is my cursor not working? There we go. All right, so same thing as we talk about every single time. It's the fundamentals that we got to go over, and just so y'all are aware. All right, so tonight, what I want y'all to get out of this is some behaviors that people pose that can endanger us, themselves, bystanders, anything like that. That's really what we're kind of want you to get out of tonight. Get you a basic understanding of mental health, some of the assessment and management skills of how to approach them, how to talk to them, kind of what you need to do. But we'll go over the acute psychosis, suicidal risk, agitated delirium, uh, and then kind of hopefully get you some information that y'all can go off with. So most of the time, we see these patients during their crisis. We see them when they're having, obviously, as you can see, the acute medical situation, mental illness. We see a lot of mind-altering of substances. I guess that people find them, or either they're like, "Oh no, they've overdosed with me. Now I got to call somebody," and they find them by themselves. Stress is a big one. Really big one. 10 minutes. I promise I'll turn that down. Um, Stress causes a lot. Can cause you to break down, can cause you to have mental issues. So all that's in there. And obviously we know there's several other things out there that could cause that. Oh well, here's the yawning. I'm sorry. All right, so here's a few things that I've added in here. Obviously the orange will kind of tell y'all. Here's another acronym so y'all can learn. We'll talk about some of the behavioral changes, and always, just because they say they are psychotic or they have something, there could be a something to relate it back to. So their behavioral changes and their physical mind state and what they're doing could relate to something that's underlining that nobody knows of. So here, men to mind is something you can think of. So we broke it down for metabolic emergencies. You can go with Cushing's disease and electrolytes. Electrical, think about epilepsy. Maybe there was a seizure on the front of the forehead. Nutritional, thiamine, folate deficiency, anemia, drug toxins, street or medical drugs. Arterial, it's a stroke or a TIA. And mechanical, brain injury, subdural, epidural hematomas, maybe from a trauma, could be from a recent fight, a recent uh, Brad, Robin, I'm assuming you're talking about our speaker, or I'm just fussing about that, or the yawning. I'm sorry. I'm with you now. I don't know. It's every time I get on here, I start having yawns, so I don't know what the deal is. I think it's just trying to make sure to stare at these screens and get everything situated, but I'm sorry. We'll be all right. I guess y'all can keep making fun of me, but I'll take it and run with it. Uh, okay. So back to this. So infections could be from HIV, syphilis, meningitis, hepatitis C. I am. I got woke up at 2:30 and 4:30 this morning, so I am a little tired. Um, Neoplast, primary or metastatic tumor, and then degenerative. Jeez, they need to stop. Degenerative, Alzheimer's, Parkinson's disease, multiple sclerosis. So think about those things when you come across somebody, but that Mendamon is kind of what they use out there to do another mnemonic to think about things that are going on. So go to the next one. All right, so now we'll start talking about what the book wants us to learn. Myth versus reality, and myth and reality. Some point people are experiencing an emotional crisis. We can either be a birth, can be a death, can be a traumatic incident. It could be just because they lost their shit. I mean, we know people all the time that just be like, man, they were cool and all that, but they just lost it. Um, not necessarily diving off into the PTSD, but that's later in the chapter. But that could be some of it too. Um, when we say that, it's not saying that every single person is gonna have a mental disease or mental issue, but at the same time, oh, what's the class posting? All right. So, but at the same time, it's more common to have mental issues and mental crises than what it used to be. Um, it says otherwise healthy people may sustain acute or temporary mental health disorders. Obviously, like I've told you before, don't jump to conclusions concerning yourself or your patient. They may not be dangerous, they may not be, but they may just be blowing their top because things have happened recently. Time of year is a big thing, so it causes these mental breakdowns. What is wrong with my cursor? Hang on, all right, next one. I am All right. So the most common misconception about mental health illness is that you're feeling bad or depressed, and you might be. Obviously, y'all can hear what we go through. Let me go turn that down before y'all have to hear any more about it. All right, so Jason, phone in line one. So y'all can explain that to y'all. So we have to fly on helicopters to and from work, and everything's weight based. How many people we can fit in the helicopter versus what size helicopter comes out. So yeah, just remember that. That's the reason why she fusses at us all the time. All right. So just because you're sick doesn't, when you have these depressions or you feel bad or things just, you're not, the misconception out there is that, oh, they must be sick or they crazy. No, it's not necessarily. We can break them down into several different classes. The ones that they talk about here is divorce, death of a relative or a friend. Could be a multiple different reasons. Death, the stages of death. It's personal issues that you may be going through. So all those things can affect mental states and the functionality of ourselves. All right, there we go. Many people believe that an individual with mental health disorders are dangerous, violent, otherwise unmanageable. Well, that's not necessarily true. That medication, well, nowadays medications are more accessible. They don't lock you in a mental institution when you have problems or you're not the norm, which I've always wondered what the norm is, but they treat you. They can treat you with medications. They have a lot better understanding of some of these mental issues than what they used to have in the past. And that's where the classification and the misconception came from, where, oh, well, they're sick. Then you get that mental, that stigmatism that's put over your head that, well, this person's just crazy. Well, maybe because an individual made them that way, but so they're not treated that way, and they're actually treated and managed very, very well. Not all of them are going to be violent. Some of them, a majority of them can be dangerous and both can be violent, but you can still manage them very well if you know how to talk to them. Just talk to people. EMTs may be exposed to higher portions of violent patients because that's what we're called for. We're called because this person is either off their medications, they've lost their mind, and due to the situation, it causes them to be violent. Um, I don't know what triggers it or anything like that. I'm not that smart, but that's just some of the things that we get called for. Many people believe that individual. Oh, all right, there we go. Although you cannot determine has caused the person's crisis. I mean, you may be able to predict whether the person can become violent by their just appearance. Y'all know. I mean, you see people, you're like, oh no, he's fine. We can come over there. We can talk to him. Just as in general life. But then the next one, you're like, nah, okay, that dude crazy. We're not going over there. I've seen him go nuts. Well, it's the same thing in EMS. When we go to these people and we start talking to them and working with them, we're like, I don't know. I need to build a rapport with this dude. Hey man, what's up? Can you hear me? And they start looking at you and rocking back and forth. Well, I'm gonna keep my distance on those. I'm gonna make sure I stay my 15 feet apart, if not greater. I may have to holler at him, but that's not my problem. I want to stay safe. Um, the definition of a behavioral crisis is when you can see a person's response to the environment, his or her reactions. So most of the time, people respond to environment emergency and to the environment in reasonable ways. Over the years, people learn to adapt to a variety of situations in daily life, including stress. Sometimes stress is so great that the normal ways of coping are not enough for a person's uses negative coping mechanisms. So we have withdrawals, we have drugs, we have alcohol, we have, I mean, heck, you've got a small computer at your hand, so everything out there can be a coping mechanism. But if you don't have those ways and you don't have the medications and you don't have the drugs or alcohol, that's when you may start to have a crisis. Well, it's hard to just teach you that without saying you'll find out. And I don't know if you want to say that's fair in life, but I mean, some of these you're just going to have to get out there and experience and hope that your partner is worth a crap and they help protect you and they don't hurt you in the main because they're like, oh no, Fred never does anything. And then Fred, starts attacking y'all and y'all are, harmed. So that's one of those things that I'm like, you just need to experience this. And that's kind of how it happens and what you see. So the change in behavior may consider inappropriate or not normal by the person who calls 911. And people react to stress that we all act to it differently. We may just be like, in stressful times, I like to go shoot. I enjoy shooting. I enjoy recreational shooting. Unfortunately, it's so expensive to do that now. I don't do it. I just kind of cope with it different and be like, I'm good. We'll be all right. So, and I just kind of deal with it. Whoops, I deal with it in my own way. So that being cool is I I hate trying to answer text messages and talk to you all at the same time because I can't do it. So we all handle them different. Some of you guys may go work out. Some of you all may go driving down the road. I don't know. I mean, but we all answer to them differently. So, but the way that people respond to you is how you're going to get the call. So if you're having a non-coping moment and you start just hollering at somebody, then that's going to create an issue. So these people are going to call 911 on you. And then that's where we get involved as an EMS in general. So you may be fine, but somebody perceives you as not. And that's how EMS gets called. So a behavioral crisis or a psychiatric emergency includes patients of all ages. I've seen them from 5, 6 years old to well into their 70s and 80s. So it's a person who is exhibit agitations, violent or uncooperative behavior, who are a danger to themselves or others. Well, that's a lot of times where the police get involved also. So EMS is called when the behavior has become unacceptable to the patient's family or community. Well, and another thing, the reason why we're called is because people don't want to deal with them. Well, I just want y'all to take them. Take them where? I don't understand what you be like. What you mean do? Take them to a motel? I mean, I'm not real sure how you want me to treat this, but all right, I can work on things, and unfortunately, we may have to take them to a psych ward to where they're going to be held for 36, 48 hours. It just depends. But that's how the system works, and it's not saying that we enjoy the system or the system works for the best of us. It is what it is. That's how the the health system has been depleted of money, so the mental health system kind of gets put on the back burner. So a patient may have dementia or depression, behavior that may interfere with activities of a daily living. So chronic depression, a persistent feeling of sadness, despair, maybe symptom of mental health disorder. Those, I don't know what, I know some of y'all are in Louisiana. I don't know where some of you are, but in our area, Mississippi, you go off of Region 8 mental health care, our health facility. That's kind of the ones that run the state of Mississippi. Um, so that being the way that is that they're treated there, and over time, it's it's just they're a mental health, they're a Region 8 patient, and they have somebody to talk to. They have a crisis worker instead of somebody that's new, and you're like, freak, I don't know what to do because now I got to take them to the hospital, and they got to go through this system that sucks because there's no money there. So, as you can tell, I don't believe a lot into the mental health system. It's been destroyed. So usually if an abnormal or disrupting pattern of behavior lasts for a month or more, it is a matter of concern from mental health standpoint. When a psychiatric emergency arises, the patient may show agitation or violence and may become a threat to themselves or other. Now, it's not that they're depressed at themselves or they're upset. They just don't know what else to do. And sometimes they're the reason why that they feel the way they are. And they know that they feel that the only thing to do is just to harm themselves. Or something on the inside is telling them to do this. And that's where their mind is telling them what to do. So it's sad, and that's why that they may, be harming themselves, and then they're like, oh nope, this person's here to kill me and take me and lock me away. Well, no, not really. I'm just trying to get paid my 12, $13 an hour, honestly, and I have cold food in the truck now because of you. But that's the mindset that we as EMS providers get run down and burnt that we're going to go to when you see this person over and over. And I hate to say we should never be that way, but we all are. We all are kind of depressed at times when it comes to EMS and work and how do you handle things, and you feel bad for people after a while. So mental health disorders, according to the National Institute of Mental Health, mental disorders are common throughout the United States, affecting tens of millions of people each year. A psychiatric disorder is an illness with a psychological or behavioral symptom that may result in impaired function. Um, Obviously, anxieties are some of the most common. I guess I'm lucky because I don't have some anxiety. I deal with some family members that do. Um, there's a few things that aggravate me or agitate me, but it's not more of anxiety. I know like people like get so stressed because things are going on that they pull their hair out or they grind their teeth. So, and it affects a lot of us, and it's okay to have it. It's not oh, that person's sick. But there's things out there to fix it. We just need to recognize it as providers and move forth and get them to the best facility that we can. So some anxiety disorders include general anxiety, panic disorders, social and other phobias, PTSD, obsessive compulsive disorder. Now, a person can get multiple of these together. Um, it's not saying just because you have one, you can't be in other classifications. No, I mean, social or other phobias, I hate big crowds. A lot of those are because of the Middle East. I don't, I say that I don't have PTSD, but there are some triggers that trigger me versus some of the just non-stressing things. Um, it is weird. I do carry earplugs with me pretty much all the time in case things are just to where it's normal, but I can't function just because it's so loud and it's personal. But I handle things a little different. So, and I have friends that it's very bad because of what has been done in the Middle East. They've lived through things. They've held friends in certain ways. And we deal with that in the US too, that people go through the traumatic disorder and it's very hard for them to move forth and they constantly have to deal with it over and over. But you can get multiple of these together instead of just one. You can be diagnosed in several different orders. The U.S. health system provides many levels of assistance to people with psychological conditions, but that money has drastically been cut. So it's very, how do I say it? It's been much harder for people to receive treatment and the assistance that they need. More serious issues. Oh, hold on. Professional counselors are available for marital conflicts and parenting issues. I'm sure they're busier right now because of the lockdown and COVID and nothing's open and people's all bunched in together. I would love to see the statistics of divorce rates, spousal abuse, breakups, suicides, and all that after this COVID is over and they can get those numbers together. And not everybody dies of COVID. I'd like to see those numbers just as a personal thing. We can see there more serious issues are handled by psychologists if they are able to get into the system and see those. But a lot of that is hard because of financial issues. So, and then severe conditions require a psychiatrist. Well, seeing a psychologist and a a psychiatrist takes money. Somebody has to pay for it. I don't work for free. You folks don't work for free. You'll put your hard-earned money into things and you want stuff out of it. Well, when you need it, they still want money. So that's another reason why we deal with a lot of these things is because they don't have the funds to pay for it. And where do you get these funds? So there we are, EMS. Um, Most psychological disorders can be handled through outpatient visits. Sometimes they can. Some is what I say. Some people require hospitalizations in specialized psych units, and they get pretty intense in there. Like it's scary from somebody from the outside that goes and either picks somebody up or you take somebody there and you're like, bro, well, why are you locking me behind this concrete wall? Like I want out of here, and it's just for mental health treatment. So some psychiatric disorders may have underlying causes. We talked a while ago. We went over some of this. Social and situational stress, such as divorce or death of a loved one, disease such as schizophrenia, physical illness such as diabetic emergencies. I'm not really sure why that one's in there, but I couldn't get rid of it because that's a national component. Physical illness such as diabetic emergencies, chemical problems such as alcohol or drug use, biological disturbances such as electrolyte imbalance. We talked about that to begin with, and that was our mnemonic that we went over, kind of help you with those. Um, like I said, it's not your job to diagnose them, but we want you to understand them, and they're classified in organic and functional. Uh, Hold on just a second. I gotta look ahead. Okay. All right. So want to make sure I was on the right page. All right. So we're gonna go over the organic disorders. It's kind of what y'all already showed y'all on that mnemonic, but I didn't realize it wasn't broke down like I was looking for when I went over this. That's why I added those slides in there. So organic disorders or brain syndrome is a temporary or permanent dysfunction of the brain caused by disruptance in the physical or physiological function of the brain tissue. Causes include some of the things we went over. Drug and alcohol abuse can be some of that can trigger some of these disorders. Withdrawals completely can cause some. And then we talk about diseases of the brain and Alzheimer's and meningitis. So we already talked about that. So y'all had a little idea before we dove off into that. So I broke these down so you can understand why these are classified to show as an altered mental status. So y'all should know what hypoglycemia is. I pray that you already know it, but I'm gonna break it down more. So hypoglycemia is associated with an acute increase in epinephrine, which contributes to neuropsychiatric symptoms, including anxiety, symptoms associated with anxiety such as shakiness, sweating, and heart palpitations. And that's because it's called of low blood sugar. Okay? So hypoxia occurs when there's not enough O2 getting to the brain. The brain needs a constant supply of oxygen and nutrients to function. Hypo means low air. I'm not promise you I'm not talking to y'all like y'all don't know, but I talk to myself and I'm using my hands. So y'all, I'm not saying I wish y'all could see me, but I hope you understand because I'm talking with my hands. That's why I break it down the way I do. Impaired cerebral blood flow. Whew. The interruption of blood flow can be caused by a blockage leading to more common ischemic stroke or by bleeding in the brain leading to more deadly hemorrhagic strokes. So that right there could be because of a clot, could be because of a trauma, but that's why that is falls under a psychiatric emergency. So hypothermia or hypothermia, we know these are temperature regulated issues, either high temps or low temps. That is the absence of the physiologic change. Altered mental status may be an indicator of a psychiatric disorder such as a bipolar disorder. Oh no, I didn't. That's not that for hypothermia. But y'all know this is a temperature regulated. I think I copied something else and put it down, and it wasn't supposed to be in there. So that's why those fall into that category of organic disorders. All right. So functional disorders. This is what people can normally cope with, deal with, and work. I ain't gonna say that they function well, and I'm not gonna say that everybody out there don't need a little bit of medications, because I can tell you, sometimes I need something to speed me up and then something to slow me down. I don't know. That's just me. All right, so functional disorder is a psychological disorder that impairs bodily functions when the body seems to be structurally normal. Examples include schizophrenia, anxiety conditions, and depression. The chemical or physical basis of this disorder does not alter the appearance of the patient. So, right here, safely approach a behavioral crisis. I wouldn't stand that close to somebody and I wouldn't be crouched down to them. Of course, my knees, this knee right here is I probably need a surgery on that one, but I'm not gonna hurry up and get out of the way. So watch how you get close to them and try to learn some techniques on how to talk with somebody. Don't agree with them when they tell you they see some spiders and snakes and stuff growing out the roof, because that's not a good idea. Because eventually you're going to get your butt whooped because you agree with them, because they trying to get them off of you too. And when that happens to y'all going to message me one day and be like, y'all were right. I agreed with them and I got my ass whooped. So I'm just going to let y'all know it's out there. So your distance and the way that you talk to people and certain tactics is going to be the best thing for you to learn. And that's going to be in time and how you talk to people. Some of these things we want you to do. Ensure you have means of communications, and that's not just with the patient, but also with your, excuse me, with dispatch. Radio, not saying by phone because it may be too late. You may be involved in an altercation when it's time to talk by phone to somebody. Um, so you want to learn how to de-escalate it. The person's agitated. Try to calm them by your measures. I'm sorry. Calm them by your general presentations. Calm them any way possible, even if it's just saying, "Hey, are you hungry?" and you give them your cold food. It doesn't matter. Just try to get that patient to build a little bit of trust in you. Uh, be direct with this patient. You want to don't just up and leave them once they build a rapport with you until you get to the hospital and tell them, I've always told y'all, don't judge them. Be very honest. And when it says reassuring, just reassure them that they're going to be okay. Obviously, don't fight with the patient because it's not going to turn out good for somebody. I don't know which one of y'all is going to be good for, but that's on y'all to figure that out. I hope you don't fight with the patient. And just be prepared to be down a little bit longer. Be prepared to, um, this call may take a couple hours just because of the way that you need to be with them. Um, so we should know the scene safety. It goes with, is it going to be okay? Is it clear for me to get in there? Do I need law enforcement, fire department? Do I need the National Guard? Y'all know, but if you don't feel comfortable and go into this, even if you've been to the same guy over and over and over, it may just be that one time that he goes crazy and hurts y'all when he doesn't see police involved. Um, when it's saying legal issues, is it like mother saying one thing, father saying another thing, that they want the kid to be transported? No, I want him to go here. Those things get involved there. And I mean, when it comes down to that, you're going to need law enforcement there anyway, because it's not for us to make those legal decisions. And even majority of the time, a medical director is going to basically rely it back on to what is law enforcement saying. And it depends on how depth you get with your med director, on how they may change it or re-advance it or something. But most of the time, it's just going to be a legal issue that law enforcement's there. So just because we find a patient in a park and they're going off about a particular thing, does their chief complaint or their behavior, does it match where they're at? Um, Maybe they were dropped off there. Maybe they ran from somewhere and they've just reacted to what's been going on. So that being the case, is they, oh, um, if it doesn't look right, be careful. Uh, Legal issues involve crime scene, uh, consent, refusal. You know, we got to have consent to put your hands on them and touch them, even if they call 911. And again, man, if you need help, don't wait till you're getting your butt beat to call for it. Call when you get there and realize things just don't look right. Mechanical injury or nature of illness. Determine the mechanism of injury. If there is an injury, or is it just a mental illness? If it's a mental crisis, illness you got to deal with, um, handle it that way. If you notice medications, drug syringes, and it may not be theirs, but you can note it. So just in case, be like, well, there was some paraphernalia around the scene. There were multiple people there. I'm not real sure whose it was, or so I found some medicine in a bottle, in a jacket by the patient. The patient said that was not their jacket, but here's the medication. Or I took a picture of the medication and I left it there because it may be somebody else's and they don't want to get involved either. Um, we know primary assessments. I hope y'all do. I've preached about this every class so far. You get your general impression from the doorway. Don't get close to them. Stay away from them from a good distance if you have to. Um, Begin with an introduction of who you are. Build that rapport. Build that just, hey, I'm here to help you. I'm going to be okay. Everything's going to be okay. How are you doing? If you see things on this physical exam, and I mean, you're not going to touch them, but if you see things, say, hey, is there a way that I can fix your arm? Is there a way that I can come put a band-aid on that so you won't get any sicker? Infections. Just try. If they say no, okay, don't push, don't, on your own. So you look for trauma. Maybe is there trauma to the head? Do you see any bruising, swelling? Um, Observe the patient closely to check their AFPU. It may not be very obvious what's going on, but if you get too close, are they playing possum versus are they really just to get somebody closer? Most medical and trauma situations will include a behavioral component, Treat the whole patient, not just one of them. The behavioral component as well as the medical or traumatic issue. That's hard. I mean, just sitting here thinking about if this patient's schizophrenia, if they're schizo and they're involved in a traumatic incident, whoo, Jesus, you may be allowing John to talk to you and treat, and then the next minute Suzanne comes out and she don't want you touching herself, and you're like, oh, what? I was just talking to John and he was good. Who knows? But think about that. That's nightmare in my mind. That's nightmare. Just trying to figure that out. Are they breathing? Are they not? If they talking to you, good. If they acting a fool and PD's wrestling with them, good. That means they were breathing. They at least got a heart rate too. If you can, pulse ox them. If not, it is what it is. You're gonna have to get vitals somehow or another. Hopefully they will allow you to get vitals. Hopefully they will. Maybe they won't. I'm not 100% sure, but that's the plan because eventually we need them. Circulation, basically you look for the red stuff that's outside of the body. We want to make sure we keep the red stuff on the inside. And then we can check all that by vitals. When we go to check them, if they allow us to, you can check the skin color, temp, and capillary refills all at one time. And then when you step back away, you already have a good baseline. And then where are we going to transport them? I'm not taking them to the Band-Aid station that has no psychiatric help. The psychiatric hospital may be on the other side of town and take 50 minutes to get to, and it's 20 minutes for your time off. Been there. I get it. I know. So if there's a way to investigate their chief complaint. They don't want to talk to you, don't talk to them. Just try to be, okay, I'm sorry, I was here to help you. Some of the questions that consider three main areas of contributions. Is the patient's cervical nervous system functioning properly? Are hallucinogens or other drugs or alcohol a factor? Are significant life changes symptoms or illnesses caused by mental rather than a physical factor involved? Has something recently happened that's causing this? Are they, let's see, is it due to a recent incident within the family? A death? Maybe sudden divorce was proposed by one of the spouses. That can cause all that. And then now you're like, I don't know what to do with you. Hey, how are you? Look for illicit information. It's not available to hospital staff. Ask about previous episodes. What kind of treatment they got? Did they stay in the hospital? And or are they given medication that they're not taking? In geriatric patients, consider Alzheimer's, dementia. Is there any other abnormal behavior that they can have? They can get away with it. Like kids and elderly can get away with being just true buttholes and do whatever, and they're like, hey, they're old. No, look, they're cute. They're young. Sometimes I can't wait to get there, just because. Determine if the patient's mental status to guide treatment to transport decision. This information will also be extremely helpful to the hospital personnel. So, how do they normally act? If there's somebody around, be like, yo, hey, bro, why is this patient like this? Is this normal? Well, when they say yeah, and you're like, oh, Jesus, oh, Lord, here we go. Now you know, hey, what you see is what you get, because that's normal. They just moved here, and now he's our problem. But if the family says no, like this just came out of nowhere, now you have somewhere to go. Obtain information from family, friends, caregivers. Your assessment of the situation has two primary goals. You'll see right there. Recognize major life threatenings, reduce stress situations. Use reflective listening to gain an insight into the patient's thinking. So, repeat in a question what the patient has said. I understand. Now, let me get this right. I understand that you're saying that your right arm hurts because you slept on it wrong and it was in a cast. Yes, that's right. That's what I said. Okay. So then encourage the patient to expand on their thoughts. Now, don't agree with them, but give them the opportunity to speak. Give them the opportunity to express what's going on, just because it's for the betterment of the patient. Because now you're building that rapport, that ability to just work with them. And now they're like, oh, maybe this person does care, and I don't know anything about them, but they listening to me. So in your book, 22.2, here's some mental health disorders, some questions. Y'all can go over that. I'm going to give y'all a second to read it while I take a drink of water. And the thing is, like we're looking there, does the patient appear to understand me? Well, that's important because now we're able to judge their mental status. Or are they okay, or are they just, like we said, crazy? And does the patient's expressions, disorders, thoughts, delusions, or hallucinations? Well, I can tell y'all from experience, you may not want to ask sometimes. What do you see? Well, guess what? Sometimes you just need to leave that shit for the mind and for them to just tell you later or never, because you'll hear some crap that comes out their mouth and you're like, oh, I don't know why I asked that question. I promise you, it's going to happen. All right. Is this patient awake, alert, and oriented times 3? And if y'all don't know what I'm talking about, so that would be awake, alert, oriented times 3 to person, place, or time. Just FYI. All right. So is the patient unconscious? Begin with a physical exam to look for a reason why the patient is unconscious. If conduct a detailed physical exam and obtain a complete set of vitals. Obtain vitals only if it's possible to do so without worsening the patient's emotional conditions, because they don't want you to touch them. Make every effort to assess blood pressure, pulse, respirations. Now, it may not be the best idea to start sticking them with a CBG to check their sugar because they all pissed off. Now you're creating some pain. I hope you brought some good up, because they're not gonna get happy. Consider whether prior events such as a physical agitation, use of stimulants, alcohol withdrawal, a taser exposure may be contributing to the patient's conditions. I've never seen somebody, I'm not gonna say it's not possible, I've never seen somebody lose their crap over being tased. Now, yes, I promise you to God, it hurts bad. But understand, that's 5 seconds, folks. I've ridden them 3 or 4 times on the taser. Not against the law. Y'all quit thinking bad about me. But I haven't seen that. Not saying it isn't possible. When examining a patient with a behavioral emergency, check for track marks. Shows you if they're a drug user or not. Or check the wrist, the stomach. Maybe they cut themselves. Maybe they're self-mutilations. And that's how they heal, is by dealing when they inflict their self-pain. A conscious patient's probably not going to answer your questions because they don't want to talk to you, and they really don't want you here because you need to go. That's really the best answer you're going to get. Facial expressions, pulse rate, and respiration. I'm probably not going to get that close if they're alert and their facial expressions look like they going to come kill me. I've told y'all multiple times, I like myself. I don't need somebody to rearrange things on my face for me to be like, oh, I feel like I'm better for that. No, so fair warning. I'm answering the other instructor. So fair warning, be careful. Um, so some telltale signs that may give it away that it's not just environmental. You may have tears, sweating, some blushing, maybe significant indicators of the state of mind because the body's hot. Uh, hey, can everybody hear me right? I know there's 9 of y'all. We're obviously having some trouble with this program, so I just want to make sure that everybody's hearing me. So obviously the EMTA all got kicked out. Um, the instructor literally said that to let them log in and the program shut the computer down. I think that's what happened to me last week when I had to kick everybody out as fast as I could and try to get back on. It was rough. So we're gonna keep going on. Somebody just let me know if y'all happen to hear things. You don't hear me key in later on. So if you see that bottom statement, a patient, a blank glaze, or rapidly moving eyes, or mean central nervous system dysfunction, if you see that 100-yard stare, or they're staring straight through you, bruh, get some yonder. It's okay to step back. It's okay to be like, key up on your radio and be like, hey, headquarters, we need PD out here now. Because I'm not going to say that they're going to harm you, but at the same time, they may be getting ready. So they may come after you, and that may be their prep phase to just. I tell you, those every time I've seen the blank glaze or the staring in space is one of those. There's look right through you, or they give you the eyes of hell. It's always not a good time. So fair warning, and be cautious for that. Oh. All right, so transport decisions. If it's two ladies on the truck, two men on the truck, doesn't really matter. Doesn't matter if it's male, female. It doesn't matter at all. If you need extra support, then do it. I think this one's funny. On my notes, it says transport by ground rather than by air. Well, that's the stupidest thing that they got to put in here. But the problem is that they got to put it. That's the funny part. Um, if you're able to transport them and you have assistance and you have a rider with you, it may be most appropriate for that to take place for the safety of everybody. Is there a specific facility with the patient in psychiatric emergencies? Most areas all have those specific places for mental health. It ours in our area is our trauma center has it, and then our one of our other hospitals specialize in it. So those are the two areas that we go to when they're in need. Never let your guard down. I'm gonna tell you, they will come at you, and then when you least like, oh no, they're good, everything's good now, it's good to go. So that's when they're gonna come at you. What else here? Many patients experiencing a behavioral crisis will act spontaneously. They will come out of nowhere. Be prepared to intervene quickly if it's safe. If restraints are necessary, reassess and document the patient's respirations. Assess as well as pulse, motor, and sensory function restrained extremity every 5 minutes. Because you can easily, let's say, injure the patient, you can cause respiratory distress, which would lead into distress. You restraining them may cause them more anxiety, and the blood vessels are going to constrict, and it's going to be very hard for them. I have multiple times restrained people. I've chemically sedated people to transport them. It's one of those things. It's needed. We just gonna have to we have to do it in our career. So that may just be something you come across in time. Um, some interventions. Man, there's not so much you can do out there. There's very little time to stuff. Very little minor things we can do for them and the times that we're with them to transport. Uh, the best thing we can do is like the second one, which says diffuse and control the situation if it's able. If we're able to diffuse it, that's fine. All else fails, you may just have PD transport them and you follow them because it's unsafe for them to be in the back of an ambulance because they're that rowdy. Um, Intervene only as much as it takes to accomplish these tasks. Be aware of standard precautions. They may have something, they may hurt you. Well, it says think pharmacologic restraints, as in chemical restraints. But again, you got to get close to that patient and potentially lay hands on that patient to hold them down long enough for a medic to give them a shot. So it may be just as hard. Communication and documentation, it's a lot. There's a lot to document when it becomes to a schizophrenic patient, and I don't mean just schizophrenia, but to a mental crisis issue, you got to document a lot. Because this may go to court, this may go to the mental health care worker. So let's see here. Give the receiving hospital advance warning when you're coming in with experiencing a psychiatric emergency. Many hospitals require extra preparation to ensure that appropriate staff and rooms are available. Whether restraints will be required when the patient arrives at the hospital. Communicate to the hospital things you observe at the scene that may help explain the patient's situation, such as observed behaviors. Maybe you've talked them down. Maybe you did find medications. Instead of bringing them, you took pictures because it was a crime scene. Uh, yours may be the only documentation about the patient's distress. Psychiatric emergencies are fraught with legal danger, so document everything that occurred on the call, particularly in situations that require restraints. Very particular. Very, 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 very document, document, document. And if it says at the bottom, if restraints are used, which type and why were they used? Maybe you got permission from med control. Maybe he was harmful to himself and or others, and it one of those instances is you moved in. It was for his safety, his or her safety. So you need to make sure you document that. We're gonna hit these last five, and then we'll take a break. All right. So acute psychosis. So a psychosis is the state of delusion in which the person is out of touch with reality. Now, I know y'all know that person, that friend that you're like, oh, that explains it. Their psychosis. Well, no, not really. They could be, but may reevaluate your friends. It's up to y'all. So some of these episodes that you see that you may come across, they can last for very long times or can be very brief. Uh, Maybe due to a mind altering substance, some recent intense stress. They may have already have had delusional disorders or schizophrenia. So it's maybe something that's being treated and they can't continue to treat because they don't have the money to go to these doctor's appointments. They may not have transportation to pick up their medications. So that could be part of it. Schizophrenia is a complex disorder that is not easily defined or easily treated. That's sad because these people go on and function and a lot of times get locked away because we don't have an ability to treat them. The typical onset occurs during early adulthood, with symptoms becoming more prominent over time. Influences thought to contribute to disorder: brain damage, genetics, psychological or social influences, and they have started to see this more and more early uh, into the childhood's life. Drug exposure by the parent while the child is still in the mother's womb. They have seen that not every child is going to be a drug user. You know that they come out and they have DTs too from being in the child or being in the womb because the mother may have been on meth or some unfortunate issue. Could be pills also, but that has been also linked to having some schizophrenia due to that. Um, so symptoms in schizophrenia: delusions, hallucinations, and I put in there, don't buy into the visions, because if you do, you wrong first off, but it's also going to it's going to catch in later because it's going to trigger the patient to be worse. So be very cautious of that and just don't do it. Erratic speech, we'll say off the wall things, will make no rhyme or reason. I don't know what they saying. They just talking. Well, that's part of schizophrenia. They just yeah. They get what's going on. They know it, but we just, again, we're gonna be like, they're crazy. I don't know what to do. General guidelines for dealing with a psych patient. Again, it's the same thing as we always do. We want to try to affirm them that things are going to be okay. Let them know who we are. You be very direct, and I don't want to say dictativeness, because you want to tell them what's going to happen and how it's going to happen, but don't be ugly about it. It it will help you. Your tone can also dictate some things, and sometimes these people may not be kind to the, hey sir, how you doing? Listen, let me tell you what's fixing to happen. I'm gonna need you to sit down right there, right now, and listen to me. We're gonna take you to they may not deal with that. You may have to be like, hey, sit down, and like let a cop get onto them. They're more easily to be buttholes than EMS, but just be careful of that. I like how it says maintain an emotional distance. Make sure you have enough room to get out of the way. If this patient was to charge you, do you have enough room to run and get out of the way? Well, if not, get some more yonder. You can talk louder to them. I know you can. It's in you. Um, don't ever argue with them. Just kind of be like, okay, not a problem. We can stop by Walmart on the way. All good. We're not stopping at Walmart, but don't let them hear it. Again, tell them what you want to do. Uh, Sir, here's what's going to happen. I want to make sure you're okay with that. If there's a way that I can get you to shake your head yes or no, that you understand that we're going to be doing this, this, and this. Family that is cooperative can help through this. If nobody's on scene, it's going to be a little bit harder to get somebody involved in there. Uh, Maybe if this patient is homeless or lives who knows where, and they do have somebody there, maybe you can help them. Maybe they can help you get situated, get things understood. So just try to get the trust of somebody else. I saw 7:02. Told you I get to this last few slides and we'll take a break. I will see y'all, give y'all a 10-minute break at 7:12. I'll come back and bore y'all some more. See y'all in a minute. All right, folks. We're back. I guess I know y'all are so excited. I can see you shaking your heads. Good to go. Oh, here. All right. So, I'm going to talk a little bit about delirium. Excited delirium. Delirium is a condition of impairment in conjunctive with function that can persist with disorientation, hallucinations, and delusions. Agitation is a behavior characterized by restlessness and irregular physical activities. Although patients experience delirium are generally not dangerous if they exhibit agitated behavior that may strike out irrational. In such cases, your personal safety may be considered. That's why I put in there, keep your distance, because it's important. If you get hurt, who's going to take care of you? I realize you got a partner, but I always suggest, no matter how we got this chapter, it doesn't matter if they're calm, ease, just you need to keep your distance from a patient until better rapport is built with that patient and you can see just how well this patient's going to react to you, the situation, while you're there, all that stuff. Um, so some symptoms of delirium, you could have hyperactive irrational behavior. So vivid hallucinations. Hallucinations. Hallucinations are defined as the perceptive of an object or event in any of the five senses. In the absence of the external stimulation are experienced by patients with conditions that span several fields. Now, I mean that it's just psychiatric, neurologic, and ophthalmology. That got me. That's a new one for me. Uh, Then you'll have hypertension, tachycardia, uh, diaphoresis. Somebody know what diaphoresis is? I'll poll y'all for an answer. See who's actually paying attention. Yep, right on with it, Robin. Heavy sweating, and then some dilated pupils. We've all seen those. So that's just some symptoms that you may see. You don't have to see all of them. It's going to be probably hard for you to get close enough to see the hypertension or tachycardia, but you could see the irrational behavior. They may tell you about the vivid hallucinations, and then diaphoresis and dilated pupils you could see from a distance. So maybe. So again, with these are the same things. Just be calming, be that cheerful person that I know the 10 of y'all that are in here are. Be an active listener by nodding. Let them know that you're paying attention. Indicate you understood, like we said. Okay, sir, if I understood correctly, this is what da 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 da. And then limit your interruptions of the patient's comments. Don't just, okay, yeah, let me tell you that. Don't just give them time. Let them speak. When you go up to them, very slow. It's kind of like dealing with a kid. Anytime you deal with pediatrics, you go slow, you move methodical, you just plan your moves, and you go slow. Uh, if you have to touch them, be very cautious about that. Limit that. Touch them, walk away, build that rapport. Because the more you're there, the closer they could hurt you. Don't ever let them go to the room by themselves. Don't let them wander off. Um, Stand by. I took my glasses off real quick. I gotta find my glasses. I can't read. Don't let them just walk off to another room because if they go off to another room, they could potentially grab a weapon. Um, they could get some kind of harming. They could lock themselves in a room. So don't ever leave them unattended. Now, if they need to go somewhere, ask law enforcement to go with them. If hopefully they're there. Let's see. Try indirectly to determine the patient's uh, memory, concentration, their judgment. Pay particular attention to the patient's ability to communicate clearly and make notes on the patient's apparent mood. The reason why you're going to check with that is because what's going to happen is you'll pick up if there's a change. Uh, uh, because if you notice a rapid change in the patient's ability, that's going to potentially affect you and your partner because it may present some harming ideations. Look for their personal hygiene, what they're wearing, how they're wearing it. That can tell you a lot right there. That's maybe because that's all they have. They may have left with everything they have on their back, and that may be it. And they may haven't taken a bath in a while, so that can tell you a lot too. But keep an eye, make mental notes of this situation versus that situation, because it can help you out in your assessment and your treatment later down the road. If the patient has overdosed, take the medications that are theirs with you. If PD's there, that's fine. You may have to take a picture of the items. But remember, even though you have a picture, that's still that person's property, and that's a HIPAA issue. So you can't just show them to every single person in the world. Be like, oh, hey, look who I took care of the other night, and then show some friends out while drinking. That's wrong. You need to be very cautious about that. Hello. Somebody want to talk to me. I don't know, where'd y'all go. I'm just messing with y'all. Um, so, and then the license sirens may trigger them. If that's something that is, they do medically need it, you need to explain to them what's going to happen. Hey, we will be using lights and sirens to go through the hospital. I need you to understand it's going to be okay, but this is why I'm using them. Maybe because of whatever you want to put in there. So remember that. No lights and sirens if possible, but if you got to, explain it to them. If the patient's agitation continues, you may have to get some sedation on board by either an ALS provider or contact the med control to see what they will allow you to do. Uncontrolled and poorly controlled patient agitation can lead to sudden death from sudden cardiac arrest. Physical agitation to the rest of the metabolic acidosis. They could have died and facing issues from physical control measures, tasers, physical restraints. How they were physically restrained may be an issue too. You may have to adjust their position when they're restrained because of physical positional asphyxiation. If the patient's chest movements are restricted, if their airways compromised, and I don't mean by compromise as by the patient, but if a device is put there, the way that they had to be physically restrained can cause those issues to happen. There's been deaths because of that. We've seen that in the media, so be very cautious of that. Speak up, let it be heard that you don't agree with that. We can address the patient in a different manner. Sometimes you just step back and work with what you got, uh, and then you have to just figure something else out on how to control that patient with the best interest of them. Um, Anytime you use restraints, any time, you need to call med control prior. It doesn't matter if it's physical restraints, chemical restraints, anything. Call med control. Um, it says right here, pre-hospital patients restraints reduce the possibilities of the patient injuring themselves, the potential for injury to EMS providers, and allows for safe and appropriate treatment of uncooperative patient. The the National Association of Emergency Medical Service Physicians recommends that every pre-hospital care transport provider create and follow a pre-hospital patient restraint protocol. So no matter where you're going to go, we'll have a protocol on that because that is a NIPSA requirement. The protocols are probably going to be about what types of restraints they have in there, what care must be provided when they are restrained. Your protocols must consider your state laws. So your program director will have dealt with that, worked on that. That'll be there, and it's basically signed into law by the lawyers there. So a wide variation of pre-hospital restraint protocols. I got lost. Protocols should include only the use of restraint devices that have been approved by the state health department and local EMS agencies, as in yours and your state's EMS protocols. So you have soft restraints, which include some sheets, wide wristlets, and a chest harness. Um, it's you can use a sheet to tie somebody down, and the wristlets are they're soft, they're padded. They have about a freaking 10-foot string on them, so if you have to restrain them in certain positions so they don't move around, you have those. Depends on your department, your agency, or you could have hard restraints. And they say plastic ties, which I don't really want to say like zip ties, but they're pretty wide. Handcuffs, or they could go as far as leather restraints. Majority of these you're only going to see in a medical facility. The hard restraints are always going to be in the medical facility, unless um, now, and that could be as in a state mental health care provider. So you're not going to see those out in the street. Those are always going to be left in the physical structure. The method of restraints chosen should be at least restrictive method that would ensure the safety of the patient provider. So you may get an order for a chemical restraint secondary to a physical soft restraint, and go ahead and transport them to my facility. And you're like, oh wait, what did you just say? So you may be able to do both of them. Uh, let's see. All right. So ultimately, what I really want y'all to know is types of restraints. You have soft and hard, and that you must call your med control prior to using any sort of restraints. No matter what, how often, you got to call for them. You got to learn how to use them. You got to know when to use them. And if you restrain a person without authority in a non-emergency situation, you expose yourself to a possible lawsuit and possible danger. You can't just be like, oh nope, let's restrain him. You gotta have why. You gotta know why. If you do that, you can be charged with assault, battery, false imprisonment, and violation of civil rights. Now let me tell you, I like orange, I like bright colors, but if it's gonna come down to where somebody else gets to pick the colors for me, I don't want to wear orange. Because in my area, even candy stripe, that's a felony. Orange is something they wear when they go in jail all the time. I want to pick my own color, so I'm not gonna restrain. I'm not gonna, kidnap Nalka unless you need it, and I get a doctor's permissions to restrain you. The only time I'm gonna use physical restraints. So remember that. That's most important to always call first. So if you restrain somebody, you're restraining them to protect you, themselves, from any sort of injury. So this, look at his wrist right here. So these are soft restraints. Those are wide wristlets. They fit around there in a two-piece manner, and they cup right here. A piece goes over and buckles down here, and this long nylon strap is probably at least 10 foot, at least, maybe 8 foot, but it's super long. I've seen people break them. I've seen people get out of them. I don't know how the hell they do, because we've secured the hell out of them, and they get out of them. Okay. So you may only use reasonable force as necessary to control the patient. You can't just drop an elbow on them. You can't just do the chokehold because you just want to. That's against the law. You can't do that. I will tell you all 100% of the times, follow your protocols. If it says you must do this, you have to do that. Um, Law enforcement personnel Some agencies, I don't know where you're at, how you do it, will only help restrain the patient if it's convenient to them. I think it's retarded. I don't know. Sometimes they won't help you, but if they do help you, that's physical backup that's going to be there for you. They can also serve as a witness and, you know, some sort of legal authority. And I don't mean by over the patient, as in I have power of attorney. And I don't mean that. But a patient who is restrained by law enforcement personnel is in their custody. So y'all understand that. If they say, we're going to cuff them to your stretcher, somebody has to ride with me. Why? Because I don't have a key to that, and if they go into cardiac arrest, I can't have them touched to the stretcher when they're metal, because if they get shocked, they can put us through there, and that's in y'all's custody. Some agencies will go with you and be okay with that, uh, but sometimes they won't. They may just be like, well, we just won't restrain them, and y'all can have fun with them. So again, protocols may help and to give you guidelines. So here again, if you thinking about going physical restraints, try your damnedest to calm them down by de-escalating techniques. If you can't do it, you just can't do it. Family, friends, we said this. Be honest, straightforward. Talking to a friend, sometimes that's not gonna work. It just ain't gonna happen, and you got to do the best that you can. Well, I don't know how else to tell you. That's just the best ability that you got. Um, and you just go with it. Um, Whoops, sorry, I'm on my different screen. So now, if you decide to do this, once the decision's been made to restrain a patient, you should do it as fast as possible. Have enough people on scene and on the same plan that when it's time to go, it's time to go. They say 5 people, but you need one person for every extremity. Um, for the 2 arms, 2 legs, they put in here the head, and the reason why they're saying is the head is because you want to control the head to keep them from biting you. Well, I don't know if any of y'all ever been bitten in a very bad way. It effing hurts. I don't know how else to tell you that. Um, it says have a team leader. It don't really matter who it is. A lot of people with law enforcement there, they're gonna be like, "Oh, we'll let y'all call it because y'all are most trained at it." Well, okay, that's true, but they may not know how to use your restraints. Again, use the minimal force as necessary. That's fine. Sometimes you may have to get a little rough, but remember, it's your job to treat them and take care of them. So if you gotta hurt them, you need to be able to say, okay, I can morally, ethically sit in a courtroom and explain why I did that. But a lot of times you're there to provide care, and if you hurt them, that's on you. You're gonna get in trouble. Um, so be prepared for that. Trying to respond to an instructor. All right. So next one. So use the force. All right. So use the level of force will vary depending on these factors. The degree of the force is necessary to keep the patient from injuring themselves. We know that. Um, you don't want to put 6 women on a dude that's 580 pounds. Well, sorry, let's say 380 pounds, and he works out in the gym. He's a gymaholic. That's not going to work. It depends on the patient's sex, size, strength, and mental status. That's going to determine your force, the amount of people, uh, what it's really going to take to restrain this patient. The type of abnormal behavior is exhibited by the patient will also explain and kind of give you some ideas of what to be prepared for when it comes down to laying hands on this patient. It's going to be complicated. It's going to be hard. It's going to be you're going to be out of breath when it's over, but you know you got to do the best thing for the patient in the appropriate amount of time. All right, so talk to the patient throughout the process. Even if you're like, sir, I just need you to relax, calm down, don't you bite me. Talk to them. We've said this I don't know how many times. Treat them with dignity. Give them the utmost respect as possible. If they're not wanting to speak, if they don't want to just listen, that's okay. I'm not real sure when they're trying to say about where the appropriate barrier protection during the patient restraint activities. I mean, I know gloves and eyes protection, but not real sure uh, how what they're replying to. So I'm not real sure to tell you what kind of protective gear to have on, um, because I've never really seen any, so I don't really know what to talk about. It says here, if possible, a provider of the same gender should attend to the patient. Well, we may not have that. I mean, I may be on a double mail truck that's going to take care of a psychiatric female. It's just what it is. But it may help to have the same sex, but I mean, you just may not have that. If they just not feeling you whatsoever, maybe call for another unit out there and be like, bruh, I just need some help out here. My supervisor, somebody can come out here and if it's of an opposite sex and help me out. That may be the best thing that you can do. Um, avoid direct eye contact, respect personal space, but you finna get in their space and restrain them. So I'm not real sure about that personal space. Uh, if you restrain them, somebody always has to be right there. They gotta be beside them to restrain them, hold them down, make sure that their ABCs are not compromised out of this entire picture, out of this entire game. We gotta make sure it's there. If the patient's spitting, you can use a surgical mask. You can place it, I mean, just like we all wear now on regular masks, put a mask over them. It's going to loop around the ear, so it's going to be really hard for them to get it off anyway. Um, Again, if the patient attempts to bite you, you can put them in a C-collar. Well, we know in a C-collar they ain't going nowhere. So that's a really good idea. I've used that twice. Once was on a juvenile that was irate, and once was a middle-aged guy. He literally just lost it overnight. Um, so C-collars are good. Uh, they're really good tools. Some of the things we have, like KEDs, for some of the younger kids, you can use them as a restraint device. Again, got to make sure it's not too tight, not restricting anything that could keep them from breathing full. Um, so we want to monitor every single thing. If they vomit, you got to turn them on their sides. If their airway, we got to be able to suction it out. Uh, what's their respiratory? Is it labored? Is it non-labored? Are they having any respiratory complaints? Um, Respiratory and circulatory problems have been known to occur in combative patients who are restrained. That's why it's so important for us to keep an eye on them. They're changing level of consciousness because maybe they're all amped up. Their dump of dopamine and their fight or flight method has kicked in, and now when it's worn off, boom, they're sleepy. Continue to assess the airway and breathing. You want to keep the frequent checks going on. For restraints are applied in the field, you should not be removed at all until you get to that receiving facility. Now, if you have them tied to your stretcher, I highly recommend always use a backboard anytime you restrain a patient because you can slide them off the backboard and you don't have to release the straps. That's just something I've learned over time. Um, you can look on your chapter in your book on 22-1. It shows you the how to implement a 4-point restraint. So that's another little cool thing you can look at. 2-point restraint technique is only allowed if your protocols will allow you. Um, Most agencies want you to go to 4, just so you can keep them from trying to basically flip out of it. Once the patient has been restrained, reassess the airway and breathing to document information. So you go pre-assessment, post-assessment. You just kind of you need to know that in your report it makes you look better because you've assessed them. You stay on top of their airway, even though they are restrained. Uh, just it gives you that better patient assessment. Sorry, I got a sick kid now. All of a sudden, she's running 100 temp. Trying to read a text message over here. Violent patients make up a very small amount of the calls that we run, and the behavior calls. So don't just think every time you're going on a psychiatric or anything like that is going to be automatically violent. The most potential for violence is always a critical. Consider yourself as a potential for violence is always a critical consideration for an EMT. Okay, sorry. I read that wrong on my notes. I don't really know how else to add to that one. So, on your history, I want to know, does this patient have a history of this? Has the patient previously exhibited any forms of hostile, aggressive, violent behavior, all that stuff? Um, when I get there, how is the patient? How are they? Are they seated, standing? Why is that important to me? Are they in an aggressive stance or non-aggressive? Are they being are they listening to what the fire or police are telling them to do? Maybe it's to sit down. So maybe they are, maybe they're not. Is the patient tense? Are they rigid, sitting on the edge of their seat? Are they rocking back and forth? That's a very good one. I need to know that. Why is because maybe they've already heard all they want. Maybe they've dealt with everything they can, and now they're like, nope, I'm mad. It's time to act. And you, when you walk up and be like, hey, how's it going? You may be that person that receives it all because you're the first one that said some shit to them, and they didn't want to hear it. Are they replying to you in speech? Are they answering you? Um, do they answer what you're wanting to know? Do they give you feedback at all? Or are they ignoring you? Again, are they making sense when they speak? Do they just ramble off with no, or when you say, sir, what's your name? And they're like, it's FU. Well, knowing me, I would write first name F, last name U. Basic stated there's a first name. That's just me, because I'm that smart aleck that writes a report like that. What's the scene? I just talked about that. Sorry. I was off in my head over here. Physical activity. The motor activity of a person undergoing a psychiatric emergency may be the most telling factor of all. A patient requires careful watching as he's tense muscles, clenched fists, that mad look in their face. They pacing back and forth. They can't sit still, and they don't want you in their personal space. Get away. I don't want you here. If you get close, I'm gonna hurt you. Well, they telling you. They telling you they don't want you there. So you keep getting in their space. That's on you, bruh. They telling you already. Um, it says here other factors for muscle control. Uh, what their history of truancy? They continually to do what they're told not to do. Do they like to fight? Maybe the cops are like, get ready, he's a fighter. Whoa, whoa, whoa! Why have I got to get ready? And their temper just blows through the roof for no reason, just poop, ready to go. Alcohol, substance abuse. Have we seen them before that reason? Um, it says depression, which accounts for only 20% of violent attacks. So just because they're depressed, I'm not going to say they're like, oh, well, I just want to end things. I don't want to be around nobody. I'm not saying that they won't attack you, but let's just keep that in your mind to keep your stance. Always be ready to go. Um, if the patient tells you voices are telling him or to her to kill themselves, believe it. Don't be like, well, what do they sound like? Is it male or female? You're buying into what they're talking about now. So be very cautious on that. Just believe it. Don't just be like, okay, well, what's the weather like outside? And then they're like, what? It's just because they're depressed. Suicide. So depression is the single most significant factor that contributes to suicide. is the common misconception that people who treat suicide, threaten suicide, never commit it, because that's wrong. They're crying for help. There's a Unfortunately, in our area, there's a local issue going on right now. One of our elected officials, our appointed officials, recently went missing. He was found. He's been having a lot of depression issues. Has talked about things. Sent some messages to people to ask for help, and I'm not gonna say they went unnoticed, but they they weren't as directive as they should have been to provide this patient with help. Um, they So treat suicide as an indication that someone is in a crisis that he or she cannot handle. They need your help. They need some assistance on what's going on. They need some help right now. They just need you to listen. And they're called, or somebody's called, because they something's going on that they're asking for help. Um, Here's some warning signs. Is there any signs of suicide? Does the patient seem unable to talk about the future? Does the patient have specific plans related to death? Does the patient have an air of tearfulness, sadness, deep despair, and hopelessness that suggests depression? So, I mean, that's just telltale signs that they they have planned it, they've thought it out. Um, they they're past the point of saying, I'm ready to do it. I'm close to doing it. Um, they don't want to see what happens tomorrow. They want to end it today. Okay, well, help them. Give them the stuff that they need. Transport them to the most appropriate facility. Here's a little chart on some risk factors for suicide. I'll let y'all gander at that real quick. Let me check the messages. Now that I see somebody's there. Stresses are real, correct. Um, by no means am I going to say is a lot of people can only take so much, and when the stresses add up, they don't know what to do. They reach for help. I say they panic, and I don't mean as in like, oh my god, what's going to happen. The stresses are overwhelming for some, and they may just need somebody to listen, um, talk with them. I say fill them out so they know that people are able to understand what they're going through. We are going through a tough time in all of our lives right now. I don't care what our ages are in this class, but all of us deal with what's going on in different ways. But at the same time, they're the same stressful things. Somebody may be having trouble paying the light bill, but the next person may be having trouble buying food because they want to keep the lights and power on at the house. Well, the next person may just be having trouble paying rent. So we all are dealing with these stresses that are causing these things that we just need somebody to talk to. And some of these people don't want to talk to us, which causes, um, sorry, that we just need to reach out and allow people to help us in different ways. Um, let's see. So the next one. Consider these as additional risk. Are there any unsafe objects in the patient's hand? What are they threatened to um, harm themselves? Are they threatened to harm us? Is the environment unsafe? Is there evidence for self-destruction behavior? Is there an immediate threat for patients to harm themselves or us? Um, are the cultural, religious, or social beliefs promoting suicide? I don't really know any of that, so I can't relay into that. Um, I can't really tell you any information on that because I don't know about a lot of the cultural, religious, social beliefs on those things. Hang on one second. Let me look something up real quick. Give me 2 seconds, y'all. Okay. So we want to check on those things. We want to, keep those things in mind. Are they that serious that they hold it and showing you that it's time and they want somebody to see it, and they may just call people because they don't want to be felt alone when they harm themselves. So that may be why that they're calling you, and now the people are there. Boom! It's time to do it. Some additional factors. Well, has there been recent trauma? If you believe they're in danger, obtain a police intervention if possible. Is the most important service you can provide for a suicidal patient is just be compassionate. Be there for them. Let them know that you're there to help them. Uh, During transportation to the hospital, be that listener. You may not have to sit beside them, but tell them, due to safety reasons, I have to sit behind you, but please let me listen to you. And you may not want to sit that close to them because they're suicidal. Um, but take them to the place that you know is going to provide care for them. Um, oh, all right. So now PTSD. So post traumatic stress disorder and returning vets from combat or patients in the States receiving PTSD. It can be right here: child abuse, serious accidents, sexual or physical assaults. People deal with this every day. Um, I unfortunately personally believe that we've PTSD'd the mess out of things. Um, People are acronym happy. Um, I don't doubt that there's issues, concerns, and diagnoses that patients need, and people as psychiatrists are they may not be able to know what. So PTSD encompasses a lot of things. So when you get a PTSD patient, find out why. If they say, oh, I suffer from PTSD, can you tell me a little bit why so I can kind of understand what's going on? Let them understand. They're saying here natural disasters, obviously war, loss of a loved one. I'm not going to say that's PTSD, but they listed here. Stressful life changes. I still don't believe that one personally. I believe more of this page is more, and add war to this one, is more of our PTSD standing than some of these. PTSD is not necessarily a result of one isolated event, it could be a couple. So, a couple of these things added together could be the diagnosis issues that these patients suffer from. It's a category that people are listed in. An estimated 7 to 8% in general population will experience signs of PTSD at some point in their lives. Military personnel who have experienced combat have high incidence of PTSD. Remember, reminders of their constant experiences in the military from news coverage or gatherings of vets can also be triggers. Gunshots, fireworks. I have issues when I go to the dentist and they take those little metal things and they drop on the tray. It makes me want to harm somebody. It just sounds like I'm being shot at, and that's what it sounds like when it hits your vehicle. Ting, ting, ting. I can make that noise, but when you hear that exact sound, it drives me out the wall. I have to wear headphones when I go to the dentist, but I still say I don't have PTSD. This is my story, and I'm sticking to it. Um, your vets are your most common. We do have a lot of vets that return. Thank goodness we don't have some wars going on right now. We do have a lot of military that are still displaced across the world. I'm very thankful for them. Have some good friends that I've lost overseas. Um, but be kind, cautious, very when it comes to dealing with your military vets that don't go to the VA because of obvious reasons, but um, just be cautious. They can have triggers too. They'll set them off. Um, so some of your signs and symptoms. Oh, sorry, not some of your signs, but some of your symptoms of PTSD are listed right there. Here comes the yawns. um, fear is a lot of it. Helplessness because they know what's going on. They just can't get it to stop. The sounds, the noises, the smells, the voices, the visions. That's a lot too. That is very harmful to them. Um, that happens. Um, People with PTSD, they may avoid things that remind them of trauma, including loud noises or smells, and sometimes avoid interactions with other people. I don't like people. I'll straight up. I'll talk to you all day long. I'm cool with you, but if I can have a choice of being alone or being in a crowd, I'm gonna go by myself. Suffer constant nervous systems arousals that are not easily suppressed. A lot of your PTSD patients smoke very heavily because of stress. They got to have something that helps them deal with that. Heart rate increases. You'll have pupils dilate. Systolic blood pressure increases because of the the situation that they're dealing with is a stressful, and they're just like, oh, and they got to have something right then. If the victim may be hyper vigilant or display aggravation, startle responses to perceived danger, they can relive this traumatic event through intrusion thoughts. They can nightmares, flashbacks, cold flashes, hot flashes. Uh, they feel like they're being attacked. I could go on and on because it's just some of those things that just deals with you every single day. Some other psychological conditions, such as personal disorders or increased functional impairment, can develop in individuals with PTSD. They can literally be complete different persons when they go to work, as in and go to war, they're deployed. They're one particular patient. When they come home, they can't function. They can't just have it. And
like a guy, yeah, like
go ahead, Sherry.
once a year, talk to sugar daddy, like whoop whoop, like okay, get your money, girl. But like this bitch was.
Hey, your mic's open, baby. So be cautious on these PTSDs and be very kind and generous to them as you can. Um, Here it shows you PTSD combat veterans are prone to having early heart disease because of the smoking and alcohol, type 2 diabetes, because when they get back, they don't have as much um, functionality. They just stay hibernation. I know, Carrie, that's exactly what I'm laughing at. It's all right, girl. We just can't help but laugh at you. Um, Another consideration for combat vets is the higher incidence of TBIs, which is traumatic brain injuries, and they sustain those due to trauma secondary to explosions of IEDs. I suffer from a TBI. I've been through that. I've seen through an IEDs. I get them. Symptoms may go undiagnosed for several reasons. They similarity to symptoms of PTSD, so they just classify them as that, and they don't want to mess with it any other way, and they don't really know. I'm gonna read this. I know exactly what y'all are gonna say. The patient may downplay the symptoms. Healthcare providers should eliminate as much noise as possible, refrain from touching or doing anything to the combat vet without explaining prior to doing it. Um, and when I tell you this, you're gonna kind of be like, huh? But keep them away from diesel equipment. The smell of diesel. Every military vehicle is a diesel. The sound of that, whoa, 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 that's what you hear. You associate that with war. So if a fire engine's sitting outside, just be like, hey guys, can you turn your truck off? But what? It may potentially trigger him. So can we be careful about that? I know that's different. It took me a while to kind of get over that, but that's just one of those. Um, Caring for those, we've talked about that. I'm not going to go over that again. If you have to ask about, let's see, if you have to ask them about suicidal intentions, be very cautious because it could trigger them more. So I'm just going to tell you, be very cautious if you have to if you do ask that. I don't know many vets that don't have a weapon on them at all times. It could be a pocket knife, a pencil, a pen, uh, a multi-tool. All I mean, and anytime you get ready to hold them down, restrain them, you better bring the A team, boys, because I'm gonna tell y'all, it's game on. It's on. It's gonna be a fight on your hands, and that's something that you may not be prepared for. I'm gonna stop right there. I see it is 8 o'clock. I will, before I start the next little bit, I will give y'all a 10-minute break, and we'll come back and try to knock out the rest of you slides. All right, see y'all in 10 minutes. All right, folks, we'll get back. We got less than 20 slides left, so I know there's an end to it, and I know y'all are excited, so I just want to give y'all some heads up. All right, so medicological considerations. The medical and legal aspects of emergency medical care becomes more complicated when patients undergo a behavioral crisis and psychiatric emergencies because it, everybody's too happy nowadays. You got to have consent. Well, the patient wasn't of mental right to consent to your treatment. We were called out there because of this. That's the reason why I try to very, very much harp into y'all about documenting well, very, very well if you're on a full BLS truck. Some of your agencies and states will allow that. So if you do the report and you went and took care of this psychiatric patient, know that your report may get called to court. So if you say it in court that you did this, this, and this, but you didn't document it, I'm not sure that they're going to believe you because I can promise you, as many times as I've been to court, if it ain't written, you didn't do it. Um, it's very important to document your things, and I'm gonna tell you, the 3 times that I've been to court haven't been within like months of it happening. It's been years of a call, and I'm like, bro, I don't know what I did yesterday. So make sure your report's good. Make sure it's legible. Make sure it paints you a picture of exactly what happened that day in that call. Once you determine that the patient has impaired mental capacity, you also must decide whether he or she requires immediate emergency care or not. A patient is mentally unstable, and a mental unstable condition may resist your attempt to provide care, but at the same time as you can't take them unwillingly. That's kidnapping. It's going to be hard to leave the patient because they don't want to go. Well, they're mentally capable of answering, but something's wrong. Uh, if you leave them, that may result to harm of the patient and expose you to a civil action for abandonment or neglect. So, that being the case, you call for law enforcement to come out there and help you with this call because you've exerted all your capabilities of getting this patient to go to the hospital. I need you to help me get them to go. And a lot of times they use a scare tactic. You can go with them or you can go to jail. Well, that's not how it works. The jail's not going to take a psychiatric patient because they don't have the ways to take them. So I don't like the fear fact. Don't try to scare them to go with you. Give them consent. So you got to have implied consent, even though implied consent is assumed with a patient who is not medically competent to grant. So if they are like you and I and all us in here, that's implied consent because they called and asked for help. Oh, I'm hurting here and here. I need you to fix that. That's implied consent. Now, consent matters are not always clear cut when it comes to like psychiatric issues because are they mentally capable of responding? Are they mentally capable of understanding what you're asking them to do? That's where it gets That's where it gets a little iffy. It's just hard to explain it because it's their mental abilities may not be there for you to be able to treat them and or get a refusal. So be very cautious. For a long time on all my psych calls, always call med control. Always, hey, this patient wants to sign a refusal. This is what's going on. Yeah, okay, you can get him signed. Okay, doc, what was your name again? And I always call it on a recorded line. So that way it's recorded and then I got it. So for a long time I did that. So here it says limited legal authority. The EMT has limited legal authority to require or force a patient to undergo emergency medical care when no life-threatening emergency exists. You need to be familiar with what your local and state rules are about that. It's good to ask those questions when you go into a new hire and or just a regular training class, or just walk up to your FTO or your supervisor and be like, hey, what can we do here, here, and here? Ask. Um, if they are A&O times 3 and they know what is going on, they can tell you to walk on. I don't need your help. Bye-bye. Hey, I need you to sign refusal. I ain't signing nothing of yours. Patient refused to sign refusal. Patient walked away from the scene. That's your report. I mean, as long as they're mentally capable, they can do that. So in psychiatric cases, a court of law would probably consider your actions in providing life-saving care to be appropriate as long as they were for the benefit of the patient. If you're trying to harm this patient, or you do something and causes harm to this patient, you done, cause you gonna lose your license. You probably gonna go to jail for a while. A patient is impaired may not be considered competent to refuse treatment or transportation, so they may have to go with you. Always maintain high index of suspicion about the patient's condition. Could be because of a TBI, could be because of a recent trauma to the head, car crash. A lot of times if they have a bump to the front of the head, I will not allow them to sign a refusal. I'm like, listen, here's why that they're not going to let you sign a refusal, because you potentially had a traumatic brain injury and you need to have that checked out because you may not be thinking correctly. And then always, always document what the statements and behavior of your patients are. It's just you gotta CYA, folks. CYA and document so much. After a while, you'll learn your way of documentation on how to do it. So it's just writing reports, asking for help, and say, hey, what do you think about this? What do you think about that? To a person that understands and that's pretty good in EMS, not one that's burnt. So always, always, always overwriting a report. All right, so for the next few slides, this is going to be more mental health about EMS providers. So we all face several challenges that about our well-being, make sure our mental health is good. This includes stress after critical incidents and chronic stress associated with day-to-day EMS work, along with the normal crap that we deal with. Mental health treatment in the form of therapy and medication can help improve wellness on and off the job. Personal health, EMS provider health, is utmost important. So if y'all want to go check this out, I actually kind of borrowed this from Bob Sullivan's article in the EMS1 article back in 19. Very, very good guy. Got his stuff together, knows what he's doing. I really enjoyed reading his articles. So I'm real big on taking care of our personal safety and personal health. So that's why I don't like the word stole. I borrowed some of his work, but I gave him props in here and cited some of his work, so we're going to be good there. Receiving mental health treatment does not mean something is wrong with you. Let's understand that again. Just because you get mental health assistance doesn't mean you're sick, doesn't mean you're wrong, doesn't mean you can't cope with things. While traumatic stress after critical incidents have gotten a lot of attention recently, there are many other factors that predispose EMS providers to mental health problems and substance abuse. Not just alcohol and tobacco, but some EMS providers go further into that because they try to mask those situations. Most fluctuations associated with sleep deprivation, challenges to healthy eating and fitness, low wages, overtime, conflict with coworkers, and unsupportive management over time can lead to symptoms of anxiety and depression. I'm gonna bet $100 to 10 of y'all have all dealt with that. Period. No matter if it's through EMS, through fire, but day-to-day activities at your normal job, you've had that issues right there. So can be related to there. So, on a national EMT survey, showed respondents overwhelmingly wanted mental health care to recover from traumatic incidents, to maintain mental health, cope with stress to prevent developing PTSD, anxiety, or depression. However, the report also states that stigma of mental illness and fear of being perceived as weak deters many respondents from seeking treatment. Only about half of respondents reported they feel comfortable even talking to mental health to colleagues. So a lot of us, and I'll say this isn't us as an EMS because y'all are coming to the world, is that the stigmatism is put out there on people. the ideas, the mental crap that coworkers say, oh, well, they can't handle it. It's stressful to them. They need to get out or put out, and I don't like that because we all deal with things different. That just shows the inability for people to process. I'm a very short, blunt, and very objective person, but I know there's right and wrong, there's black and white, and I enjoy good argumentative conversations. So people that perceive you as weak because you require assistance, there's a problem with them. Maybe they're suffering from it too, and they don't realize that they're being that bully. So mental health, along with exercise, correctly eating, which none of us ever really do, I can say, because working in EMS, you never have time to do any of that, and finding a hobby. Let me tell you, I have not had a hobby in almost 22 years of doing this. I just don't find anything that's fun to me besides shooting, and that's very expensive. So lots of people classify mental health treatment as only necessary for people with significant mental health problems, and that's far from the truth, y'all. Very, very far. Talking to someone can provide solutions for everyday stress and work life. If you go to somebody that's not in your field of work and you start just blah 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 blah, they're gonna be like, "This some like and they just gonna smile at you because they don't know what to say. They don't know how to function. But at the same time, is y'all need to understand is people in the EMS they put on a lot of front. So if you go talk to a colleague or a coworker, they may be your friend, but they gonna get to the next party and be like, let me tell you what Wally told me. It's just gonna happen. So fair warning of talking to coworkers and confiding into somebody that you know very well. That unfortunately it happens a lot. All right, so therapists and medication prescribers are the main options for mental health treatment. Mental health professionals generally fall into two categories: those who provide talk therapy and those who prescribe medications. Some people see only the one type of mental health professional, and some people see both types, which is great. A therapist may refer a client to a prescriber or vice versa, and the prescriber and the therapist can collaborate on how and what is best for you. So I'm going to tell you the difference in them. A mental health therapist have doctorates or master's degree along with psychologists, mental health counselors, whatever, all that. Medications for symptoms of anxiety and depression are prescribed by a psychiatrist who are physicians trained in mental health disorders. So now you have nurse practitioners and physician assistants, PAs, may also specialize in prescribing medications for mental health conditions, and some primary care physicians prescribe psychotropic medications as well. But when you go to some of these doctors and nurse practices and PAs, that may not be their specialty, so they're just throwing be like, blah, blah, here, take this. This will make you feel better, when it doesn't really make you feel better at all. So if you need assistance, it's okay to ask for help, but seek the right person to seek help from. Look for a mental health provider who matches your personality right there. Several NAEMT survey respondents who received mental health treatment expressed frustration that their provider did not understand the demands of EMS work, and they would have preferred to see someone with a background working with EMS providers. There's a great foundation out there that has, I'll show you at the end, that has these providers that are there and they're trained to help you out if you need help. Many respondents of the NAMT survey expressed reluctant to seek mental health treatment because concerns about confidentiality. Ding, 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 just told you. Information shared during a treatment session is protected by HIPAA, but there are exceptions such as release because of a court order. Mental health practitioner can describe exactly what information can and cannot be shared before any sensitive issues are discussed. So before you sit down and talk to somebody, they should tell you what they can and can't say and why they can and can't say anything else. Here's the most important part that I want to talk to y'all is getting into this that I want y'all to understand. Payment for mental health services may be covered by an employer health insurance or made direct to a provider. Many EMS services offer a EAP, which is Employee Assistance Program, and some of your current positions and jobs may offer the same thing, which includes confidentiality, short-term mental health counseling. This may be a good option if you're having difficulty with particular events or life change, traumatic calls, or divorce. EAPs are also a way to try therapy before making a financial investment into it. A disadvantage of an EAP is that treatment is usually limited to 5 or 6 sessions, and there are a few therapists to choose from because not a lot of people want to do it for free. It's just the way it works. Several NAMT survey respondents stated the short duration of an EAP provided therapy was not enough, and that they had difficulty relating to the therapist they saw because the EAPs are just what company takes their insurance. Here's the last one. It says about selecting a mental health provider, feeling a strong connection with them is the key. Make sure that you fit with that specialist. Make sure you fit with that therapist. Bond with them and get their trust, where you have their trust, they have your trust. That's really what that one's about. This one right here breaks it down on Sean Sullivan, who wrote the report. I'm sorry, that she was part of this legal counsels in this. And then Bob Sullivan, the one that wrote the report. Here are some of the references that he cited in his paperwork. Here's what I want y'all to see. So here's a lot of your different numbers: your American Foundation for Suicide Prevention, National Alliance of Mental Health, National Suicide Prevention, and then the safe call. So put the safe call on there is because that is 24 hours. All of them are 24 hours a day. But the safe call is it's a service for all public safety employees, all emergency service personnel, and their family members nationwide. So all counselors taking calls, they are first responders. So they understand what you and or I are going through, and they can help provide a service. I don't know the expense of any of these, but if you ever feel that in your situation and you're having these moments, that may be something that you need to reach out for. And if any of y'all have had these thoughts or had these issues, I'm not the best in the world to talk to, but guys, I'll be more than happy to help somebody any time of day. You may have to Facebook message me a couple of times, get that phone to ring at nighttime to vibrate on the side, but I'm here. I know Rob's here. We have some great staff that I know y'all haven't met everybody, but these foundations, these numbers, they're there to help us, help all of us. Your health is the most important thing in this entire career. I hope that each one of y'all understand that we push more and more and more about EMS provider health and safety because it's important. We got to continue to take care of each other, and we're not really good at that. We're only really good at taking care of others, not taking care of ourselves. I'm going to shut up and jabbering. I'm going to give y'all the class code. I got it in here. I already put it in the slideshow. So if somebody doesn't mind, will they write it in the chat for me? Because when I start talking and teaching, it doesn't let me talk in the chat. So if one of y'all don't mind, I'd appreciate it. There's your class code for the night. It is 14A16X398. Again, it is 14 capital A 16 capital X 398. Guys, I appreciate y'all. I'm sorry to bore you on that. I know it's a lot. I hope if it helps anybody, I hope it helps us all. But thank y'all so much for your time. Like I said, if I can just get somebody to copy that code in the chat, that'd be amazing. Thank you, Robin. I appreciate it. I got a little bit more work to do. Saw an email just come through. I got to answer that. Thank y'all. Hope y'all have a great night. If y'all need anything, please reach out. And don't forget, I put some questions on the Facebook page. Hope y'all answer them for me. Y'all have a wonderful night. Good night.